Well, hi there.
Hi, hi. Nice to meet
Can you
you.
hear me okay?
Yes, I hear you very well.
Well, excited to be here and to have this conversation with you.
Great to have you. And so let's start by introduction. If you don't mind to introduce yourself to everyone here, that would be
Sure.
great.
Yeah, Austin Perlmutter. What can I say? So I'm an internal medicine doctor by training. Did my internal medicine residency in Oregon Health and Science University in Portland, Oregon, and have kind of, I don't know if it's pivoting is the right word, but I've kind of migrated or morphed my career in the last, I guess, 7 or so years into a primary focus on brain health, mental health, and specifically neuroimmunology and lifestyle neuroscience or lifestyle neurobiology. And so I've had the opportunity, the privilege over the last years to work with some of the most amazing people to help to create content, messages, programs, research, to help to scale out this message, which is that brain health is the most important thing, and that taking agency over your brain health right now is the most important thing that you can do. So it's been a journey, but it's definitely been a really gratifying way to spend my time to be able to talk about these topics and to be able to interact with wonderful people like yourself who are also, right on the forefront of carrying these messages into the clinical setting and helping people.
Amazing. Great. Great. So tell us about, I like to see what is the simple way you're explaining and in a simple terms about Alzheimer's disease. So what happens in brain and how people start developing this disease?
Sure. Well, just to take a step back, so my dad's a neurologist, and so I had, from a young age, exposure to his conversations with patients, people, and myself around why brain health was so important. And one of the most kind of challenging of the brain health conditions is dementia. There are so many things that can go wrong in the brain. Movement disorders, psychological challenges, and then the issues with cognition. But what I think is so difficult about dementia, of which Alzheimer's is the most common form, is that you basically lose people while they're still here. And for anybody who's a clinician or who's out there seeing or interacting with patients with Alzheimer's, you know what this is like. You see people slipping away, even though they're physically present, they're not themselves anymore. Um, but I had some really potent examples, not just in the clinical setting, but in two of my family members. Both of my grandfathers actually had and died of Alzheimer's disease. And so, I saw these people, these incredibly intelligent and really well-rounded people. I mean, my dad's dad was a neurosurgeon, super, super smart guy. And just seeing him vanish in front of our eyes over the course of around a decade, he made it until his late 90s, but it wasn't exactly him. And still some really profound and meaningful interactions with him. But it wasn't the same guy that I met when I was younger, who knew my name, who could tell me about his medical training. So I think that's really important because we can talk about the pathophysiology, the amyloid, the tau, and all these other potential, contributors to Alzheimer's disease. But the bottom line here is that probably a number of different pathophysiologies converge to create this thing that we call Alzheimer's dementia. And just in context here, so Alzheimer's being the most common form of dementia, there's also vascular dementia, there's also frontotemporal dementia, there's also Lewy body dementia. So there are many different subtypes, but dementia is basically characterized by the generally progressive loss of higher level cognitive function. Um, and so in Alzheimer's disease, memory tends to slip away. You might lose your ability to remember names. One of the more common things that is an early kind of signal is that more complex processes like being able to do taxes or respond to complex emails, these types of things tend to slip. And what we're seeing is that rates of dementia have gone up around the world. And again, Alzheimer's being the most common form of dementia. In the United States, it's around 6 million people. Projections are by 2050, around 150 million people around the world will have dementia, again, which Alzheimer's will be the most common form. Partially, this is because of just increased populations in the age demographic that is most likely to have dementia. But we're also seeing, there was a report that just came out in the last couple of weeks, that the diagnosis rate or just rate of dementia, specifically Alzheimer's disease, appears to be going up. So they had suggested that, around 42% of people after the age of around 65 will have Alzheimer's disease, which is just an absurdly high number. It used to be, it was 1 in 3 after the age of 85. And what we all need to really take from these data points is that this is not some sort of an anomaly, an outlier, some sort of a potential. That is a huge risk to everyone. And certainly for people like myself who have a family history of dementia, there are genes like the ApoE, which is significant in the context of translating into a higher risk, depending on which of the types of APO you have. But this is a major issue in terms of what it represents for us as individuals and our personal risk of developing Alzheimer's disease. And it's an even bigger risk from a social, societal perspective because of the burden it places on the healthcare system, because of what it creates from a stress perspective in the people who are caregivers of those with Alzheimer's dementia, family members of those with Alzheimer's dementia. And kind of the cornerstone message, which is what was something that I just have seen and saw my dad talking about so eloquently, is that the best thing we can do for Alzheimer's right now, and this is to the present day in 2025, despite the advances in some of these newer potentially anti-amyloid and other Alzheimer's drugs, is preventive measures. Mm-hmm. So nobody ever talked to me about Alzheimer's prevention as something that I should care about in college. Nobody among my friends, we're in our 30s and early 40s, no one's talking about Alzheimer's prevention, even though all my friends from medical school and all my friends from residency are doctors. And yet we now understand that, like most things, Alzheimer's doesn't develop overnight. It's not like you go to sleep and you're thinking clearly and the next day you wake up and all of a sudden you have dementia. That Alzheimer's disease starts decades before a person has a diagnosis. And really, it's just like heart disease in that way. Mm-hmm. we see such an emphasis now on people going out and jogging to prevent heart disease. We need the exact same thing for dementia prevention. And so a lot of, kind of my advocacy has been around educating people on how much agency they do have over their brain health tomorrow, but also why the tools that we use to prevent Alzheimer's tomorrow are actually the same tools that will improve your brain health today. And not just cognitively, but also from a mental health perspective, the pathways are all the same. So there's a lot that can be done. But the bottom line is this matters a lot, and each of us needs to take it a little bit more seriously, and at a higher level, from a social level, from even a government level, we need to just be prioritizing the prevention of Alzheimer's dementia.
Right. That's all very valid and true. So you're working very much on preventing this disease. So tell us a little bit about your work. What are you doing, and how you're helping people?
The two, I guess, the two major domains that I've been focused on in terms of health have been really around scaling messaging. So in a one-to-one scenario with a patient, you're able to have a whole lot of control over what information they get. You're able to change lives in that interaction. But in a scaled perspective, even just having this conversation here today, you're able to reach so many more people. And so certainly a message can be diluted when it's provided at scale, right? So like just saying something on social media like, eat more vegetables. It's pretty vague, even though it's true, even though most people would probably benefit from eating more, let's say leafy greens. Mm-hmm. The relative value for an individual, how much behavior does it change? Unclear. But the idea of scaling a message remains really sound. And so I've spent a lot of time in, as I said, two domains there. One is in creating comprehensive programs for people to learn about brain health and especially how to prevent Alzheimer's dementia. And so we've done two of these programs to date. First one, 2019. Last one came out, first time was last year. The first one was focused on Alzheimer's prevention. It was through a group which is a collaboration with my dad, and we had a couple of additional partners called the Science of Prevention. And we put together this series. We interviewed arguably many of the world's experts in Alzheimer's dementia. So people who were the researchers who kind of discovered how metabolism influences the brain. Kirk Erickson, one of the kind of core exercise researchers in dementia prevention and treatment. Dale Bredesen, Dean and Aisha Sherzai, and really just kind of brought together this nexus of world experts on Alzheimer's and dementia to provide people with the tools that are best known to help prevent the disease. And so we were able to get that out to about 1 million people. And then the second of those programs, which just came out last year, is called the Better Brain Blueprint. And so that was really focused on the most practical brain health science for the average person to employ in their lives, along with actionable strategies to implement that science. So again, we just did that for the first time last year. I think we got to about 150,000 people who were able to participate in that. But these are these massive, and we launched them for free, these massive series that bring together a whole bunch of expertise in order to provide and excite people around the science that they can and should be investing in their brain health. The other domains that I've spent some time in, I guess the second of the two that I mentioned is research. So, it's funny, when I was in medical training and stuff, I never really liked doing research. I did some because it was necessary, but it was never kind of my focal point. I like the teaching a lot more. And so, but now I've started doing research. So I published a couple of first author papers in the last couple of years, one around neuroimmunology, specifically talking about how inflammation or the immune alterations in the body influences the brain and how that relates to depression, and trying to shed light on, I guess, a really specific subset of neurobiology that has been, I believe, quite misunderstood, which is that mental health issues are somehow separate from the biology of what's happening outside of the brain, and that the mind is separate from the brain, and that, for example, what we eat doesn't impact our mental health, and trying to connect the dots on some of these pathways. Now, I think we're a couple of years out from kind of the core pandemic, so hopefully these statements won't seem super controversial, but in the context of COVID, there was and there still is a lot of debate over all of the specifics of what governments should have done about it, what was helpful, what wasn't helpful. And what I spoke about in my article is that, one group of people were really concerned about the virus itself, saying, look, this virus is incredibly dangerous, that it's having all these negative impacts. And another group of people, and granted there's an overlap here, were really worried about what happened to people who were being told they couldn't go outside, and who were being told they weren't able to socialize, and who were basically finding themselves adopting a lot of unhealthy behaviors. And one of the things that was a convergent mechanism between these two groups is high rates of depression. So depression rates spiked during the pandemic. They've come down a little bit since then, but we're seeing a global surge in depression rates. And so my kind of pitch in this article was to understand that whether it was because of an infection or because of the things that people were having change in their lives, the high levels of stress, the unhealthy diet, the disconnection from other people and from nature, elevated inflammation was driving the symptoms of depression. And so, I, even in my training, learned that depression existed in two buckets. One was a psychological construct, and the other one was a serotonin construct. Psychological construct you work on through psychotherapy. Serotonin you work on through SSRIs or other prescription drugs. And now what we understand is those things are not necessarily separate, and that serotonin does not explain depression. And one of the pathways that has a much higher value, I believe, is looking at the immune system and how the immune system influences the brain in depression. Interestingly, an altered immune system in the brain has also been thought to be one of the core drivers of dementia and Alzheimer's disease in particular. So the idea around this research was really just to call attention to the idea that our brain biology drives our lived experience, and that brain biology can be influenced by a number of different variables. And when we all kind of get curious about that, we step away a little bit from pointing fingers at people and being upset because of a person's political affiliations or kind of specific belief structure, and rather ask, oh, well, regardless of where you come from, we can agree that something is going wrong in our brain biology, which is leading to all of these people having this experience of, in this case, depression. And certainly there's something we can do, whether that's diet or other lifestyle modification or kind of system-wide changes in terms of policies that decrease rates of inflammation in populations to decrease rates of depression. So that was 2021. And then more recently, I've been involved with studying a plant called Himalayan tartary buckwheat, which is unique in that it is incredibly concentrated in polyphenols, these plant nutrients that have been studied for their role in metabolic, immune, neuroplastic, epigenetic change. And the goal there was to see whether these polyphenols found in this plant had an impact on immunity and epigenetics. And so it was a pilot study, so it was not a randomized trial, but we were able to see across a 90-day period some really significant changes in certain epigenetic patterns. And it didn't seem like it was just background kind of radiation, meaning there did seem to be a very, very significant signal there. And so we're expanding this research out, but the point here being, we believe food has an impact on our health. How does food have an impact on our health? And in particular, how does food have an impact on our brain health? Well, that's where people have varying questions or ideas, right? And so historically, we've thought about plant nutrients as antioxidants, and that antioxidants are good because too much oxidative stress is bad for our bodies, bad for our brains. That mechanism doesn't actually hold out all that well in research, because if you high dose somebody with antioxidants like vitamin E, it's not like you reverse depression, reverse dementia. It's not that straightforward. Mm-hmm. So clearly these nutrients do something beyond just their antioxidant status. And so some of the things we found are that not only do these nutrients influence immunometabolic pathways, but they also seem to act on brain-specific pathways. So influencing brain cell development, glial cell function. So here again, connecting the dots between how food may influence brain function in particular, as we think about conditions like dementia. Is it possible that we can start using targeted foods for dysregulation in the body to protect the brain? So that's kind of where we're going next. But again, trying to ask and probe some of these questions around these themes that people tend to talk about but haven't been explored to the degree that will allow us to make precision or personalized recommendations around what sorts of therapies we need. And beyond that, just to drive more curiosity around what's actually behind so many of our most important brain health conditions.
Mm-hmm. Wow. What's your perspective on gut and brain link? Is there a link between gut and brain?
God?
Gut health and brain, the gut barrier and
yes. Okay, that's a very different conversation.
No God.
Yeah,
no,
yeah.
We're not talking about religion today.
Okay. That's funny. Yeah. So going back to, this year's my med school 10-year anniversary. So I know exactly how long it's been since I finished med school. In our medical training, we learned about gut health in the gastroenterology module, and we learned about brain health in the neurology module. And I guess you could argue we also learned about brain health in the psychiatry module, but not exactly, right? That was a different variant of it. But what did we learn about the connection between the GI system and the brain in medical training? Still not very much. It wasn't necessarily seen as so important to nail down. And it would actually take, going into the hospital or the clinical setting and seeing it in real life to where those questions would need to be posed. The best example I have, and I'd be curious what yours was a state called hepatic encephalopathy. And so for people who maybe don't know what this is, when a person has liver disease, when they have severe liver disease, they build up a number of metabolites. Basically, their liver is no longer able to detoxify, and they build up metabolites. And as those metabolites build up, people can become incredibly delirious, altered mental status, to the point where people can almost seem as though they're in a coma as a function of these metabolites that build up, these kind of ammonia-related metabolites that build up. And so that was not a good thing, because nobody wants to be delirious. And also, sometimes this could be pretty unsafe, especially if they were trying to be managed at home. Like, these people would become comatose pretty much. And the therapy that we used for hepatic encephalopathy then, still use now, is really two sets of drugs. One being basically laxatives, medications that increased people's bowel movements, and the other subset being antibiotics that targeted the gut. Um, and the idea here being that the buildup of these metabolites was happening related to the gut, that we were getting this issue, which was these molecules were being absorbed and the liver wasn't able to detox them. And so if we were able to flush them out of the gut, we would be able to decrease people's altered mental status, because something linked the buildup of these molecules in the bloodstream with alterations in mental status. And so these were really gut microbiome and gut targeted interventions to improve mental state. It wasn't something that was explicitly defined in that way, but that was the reality of it. And what you'd see is when people started having more bowel movements and when you started giving them these antibiotics, their brain state would clear so dramatically. They would go from being, again, almost in a coma to being fully conversant over the course of sometimes even hours. And so it was an overt demonstration of the fact that what happens in the GI tract influences what happens in the brain. But as it relates to any sort of implementation around food for the gut-brain axis, anything around the vagus nerve translating data from the gut to the brain and vice versa, anything around the immune system of the gut having an impact on brain health, none of that was really kind of core curriculum. I mean, it probably existed in more of a high-level academic conference where people were talking about some of these pathways. So fast forward to the present day, and what we see is that the science here has really pushed forward in an incredible way. And that means that not only do medical doctors and other people in hospitals and in clinics have an awareness of this connection, it doesn't necessarily mean they're doing anything about it, but it means that the general public has kind of caught on to this idea that what happens in the GI tract is influencing the brain. I think the reason for that is, one, is just a sexy new thing. Like the gut brain, it's kind of a topic of the day. And so there's always going to be some amount of people who are saying, well, gut health is the thing. But the other piece of it is actually grounded in some powerful science. And so context here would be that the GI tract, even though it is responsible for absorption of nutrients, plays a number of different roles in pathways related to brain health. And just to outline some of these for listeners and viewers, the maybe most interesting example would be GLP-1s. So people now are all familiar with the use of these GLP-1 medications as a way to lower weight. Well, what is that and how does it work? GLP-1, or glucagon-like peptide 1, is a molecule that is produced naturally in our gut cells in response to consumption of a meal. The drugs that we take, they're not just a GLP-1. So it's not as though they just basically do the exact same thing as our food. They actually activate, deactivate receptors in a way that's thousands of times more powerful than what happens when we eat food. But what they do, basically, these drugs, is they influence a gut-brain signaling system. Because what happens when a person uses a GLP-1 drug is that their drive to eat food dramatically decreases. They don't feel as hungry. They're not as motivated to eat food. That is the primary mechanism by which these drugs seem to work. Yet there's some things around influences on insulin and glucose signaling, but the weight loss component seems to be mainly around this increased satiety. The reason that works is because glucagon-like peptide 1 is a natural signal that is produced in your gut that leads to these feelings of satiety. That means that what happens in your gut is directly influencing how you interact with the world. And that's just one example. We have, for a long time, known about other molecules like leptin and ghrelin. So leptin also increases feelings of satiety. Ghrelin, which is produced in the gut, specifically in the stomach, increases feelings of hunger. And so the signals that come from our gut influence our brain and change the way that we think, act, and feel. And as you expand that another couple of steps forward, we know that molecules produced by the gut microbiome, short-chain fatty acids on the one hand and lipopolysaccharide on the other hand, can have a beneficial or detrimental effect on brain state. Short-chain fatty acids, which are absorbed in the GI tract and are metabolites of the gut microbiome, appear to influence epigenetic patterns, meaning they change the way our genes are used, including in the brain. They also have immune effects. They also may support the blood-brain barrier. On the flip side, lipopolysaccharide, or LPS, which is a molecule that is a piece of bacteria in the gut, when it gets into the bloodstream, creates high levels of inflammation. And in the brain, LPS
Mhm.
is one of the most potent stimulators of neuroinflammation, which again is linked to depression, to dementia, and other brain issues. So the key to this here is we've transcended this idea that, well, maybe it's just sexy right now to talk about the gut and talk about the brain and say, oh, if I just take some superfood powder, I'm going to improve my gut health and everything's going to get better, to saying this is hard science. What is a little bit more challenging is to say, well, what do you do about it? And I think that's something that's very interesting to me and very complicated because, again, for those tuning in on social media, you probably recognize that so much of what you're going to see online is going to be telling you kind of in a black and white absolute that this is the right thing for your issue. I think half of what I see right now on social media is ads for companies that are promoting their products as the solution to gut brain health. And one of my kind of core perspectives or points is that for anybody who is really focused on improving their general wellness, and I'm not talking about people with bona fide medical diagnoses who really shouldn't be getting advice online anyway. Like those are the people who benefit from precision medicine and personalized care. I'm saying if this stuff matters, if you care about gut health, if you care about brain health, care about mental health, the best studied interventions are always the basics. I've seen nothing to the contrary so far. I mean, this is probably the case for you where you interact with people and they're always talking about the latest and greatest new thing. It's some sort of a special wavelength of red light that you're going to shoot in through a sauna that's got a cold plunge pool and some NAD plus, and next thing you know, you're going to be the superhuman that's never going to get sick. Not to detract from the fact that there is science around that, but whether it's the gut brain or something else, I'm always going to say that there's, well, not always, until the research proves me otherwise, that the best studied interventions are still going to be doing the basics well. So just to bring that full circle, gut brain, incredibly significant. And most of what you see out there in terms of things that are going to fix your gut brain axis are nowhere near as beneficial as simply eating a reasonably healthy diet, exercising, getting good sleep, and focusing on stress pathways.
Getting to sleep. So what about sleep? I mean, of course, it's so important. We see how sleep deprivation can affect and impact our memory. And how to improve that sleep.
Sure.
What are your thoughts and perspective on these sleep aid supplements like magnesium, like melatonin, like glycine,
Mm-hmm.
more and more?
Well, I've been talking a lot. Maybe I'd be curious if what would be your top tip for sleep before I go?
My top tip, I mean, I myself hitting perimenopause and big time, my sleep is affected, waking up 2, 3 a.m. So I started religiously on sleep routine, and that was the first thing, and it really helped. It so much helped me to have that working on the routine, going gradually, dim the lights in the evening, and just stay away from Netflix, watching series, screen time, and relaxing, calming down, and trying something like chamomile tea. That definitely helped me myself. Practically, I see the change and help. Magnesium for me is a no. I tried it and it gave me so much bloating, so I stopped taking magnesium. But and then simply in the morning, starting with going out, walking, natural light. I have a dog, so I go for a walk in the morning. That helps with my balancing circadian rhythm and hopefully working on my cortisol levels. And walking is great, natural light, 10, 15 minutes. And again, I have natural light and sometimes light, so I have light at home, especially for Toronto. Early morning, sometimes we not have any light and it's too dark. So having that light at home again help to balance my circadian rhythm. So these are very basics that I always do it myself. It has helped me and helped some of my patients.
That's great. That's great. And I love what you're saying. I mean, I totally agree and resonate with what you're saying. I always feel like if I was going to design an algorithm, I guess I have some of these algorithms, but I haven't published them. It's like you got to first of all get an assessment of where you're at. And so if a person's saying, I am absolutely dead tired, I haven't slept in 3 days, and I really need a lot of help. This isn't the person that I say, well, maybe try a little bit of melatonin and see how you do. This is where it's saying, look, you maybe need to go directly, do not pass go, just go directly to seeking professional help. Because then you can work with a practitioner. They can help you understand. Maybe it's psychological. Maybe you have some sort of terrible obstructive sleep apnea, or maybe there's something else going on in your life. But I totally agree with you around the things that you did. So generally the framework that I operate out of would be to say the most important thing to start with is sleep hygiene for a number of reasons. But that's where you it sounds like have spent a lot of time focused. And so the variables there would be to say, number one, getting good sleep is just about the most important thing you can do for brain health and for general health each day. And if that's the case, you need to take it as seriously as it deserves. Most people see sleep as an afterthought. It's like, I'm going to do everything else and then just sleep. Like, it'll just happen. I don't need to worry about it. It's just going to happen. It's like, you flip the switch and then you turn off and then you're going to get good sleep. And that's just not the way that the body works. And the reason it doesn't work that way is because your brain is very kind of intelligent, and maybe more importantly, it has a set of rules within it that you can't go around. And one of those rules is that if your brain perceives it not to be safe to go to sleep, it's going to not go to sleep. So the signals that tell your brain it's not a good time, it's not safe, and I shouldn't go to sleep would be as follows. One, if you're consuming activating content before bed, and that can be just like you said, watching Netflix or the news, which is even worse, or having stressful conversations with your partner, your brain's going to perceive that as there is a threat. It is not a good time to shut down. I'm in danger. So the more you can take away those stressful stimuli before bed, the better. Another one of those signals is light. If your brain sees light, it's saying, well, this is not a good time to go to sleep. Predator is going to find me pretty quickly if it's bright out. This is not a safe space to sleep. So if you're taking in a lot of light right before bed, that's not a great opportunity for sleep. But more importantly, you want your bedroom to be dark, right? If it's light out, your brain's not going to see this as a good time to sleep. Noise is another one. And I think this one's kind of a very underrated scenario, which is that when we have noise pollution in our bedrooms, whether that's a partner who snores or cars going by on the street, that pulls us out of quality sleep. And what people don't know is even if you don't wake up, your sleep can be compromised by hearing noise. Specifically, in the second half of the night, you have less what's called sleep pressure because you've already, to be technical here, you've already displaced some of the adenosine in your brain that basically creates your feeling of sleepiness. You still need to keep sleeping, but it's not going to be as easy to stay asleep. So if there's more noise outside of your bedroom or in your bedroom in the second half of the night, that's actually going to have a much higher chance of bringing you closer to being awake. And again, I'll say, you don't have to wake up for this to be an issue. It may actually throw off your quality sleep, even in the absence of being awoken. So what do you do about this? Well, certainly, you can use sound dampening. You can put in a carpet, you can close your door, you can maybe put in curtains. But the thing that I do is I just use a white noise machine. It's a great way to create some background noise, and so it kind of smooths out and decreases your chances of getting woken up by noises. The other things are going to be, as you're getting into bed and as you're telling your body how to really wind down, the temperature I think is a really important variable. So Fahrenheit wise, 65 to 67 degrees ish, which I don't know off the top of my head what that converts to for all you Celsius people.
I always say around 18 to 19 Celsius.
That
It's
sounds
a
right.
good
Let's see.
range. I
That's
like
what
that range.
Google says. 65 is 18, so we're perfect.
Okay,
So
good.
18 degrees Celsius. So again, trying to keep it cool in the bedroom, I think, is great. If you can then have some sort of a wind down routine, just like you said, to kind of get your brain and body ready for sleep, that's a wonderful thing. Another one that I've started talking about more, which most people don't know, is the air quality in the bedroom predicts quality of sleep. So something to keep in mind, which is that if you have a polluted air in your room, it's actually decreasing your quality of sleep. So we can talk more about that if you like, but actually air quality is a huge underrepresented variable contributing to sleep quality and a number of other brain states. Other things to consider around sleep. So I think melatonin, can be used well, specifically in the context of changing time zones. I'm less of a fan of people using melatonin long term for sleep because I think it's just often one of these things that number one becomes less effective as time goes on. And number two, it's like, why, right? What is it that you're not actually addressing in the need for melatonin? Now, there's some indication that as we age, our melatonin production can drop off. And so I think for elderly people, it may actually be helpful. But 3 milligrams is really the best studied dose I've seen. Some people start taking very high doses, which are interesting, but for their immune benefits, not necessarily for the sleep benefits. A lot of these other things like valerian, lavender, chamomile, it's variable evidence in terms of efficacy. I think the biggest benefit you get is not that you're going to have a glass of chamomile tea and you're going to immediately, change your neurotransmitters and feel sleepy. It's part of a routine. If your brain can associate having a glass of tea with bedtime, it starts telling your brain, okay, this is the wind down routine. We've turned off the social media. We're not watching TV. This is where I'm starting to be told it is safe and I'm ready to go to sleep. So to contextualize all this in I guess, one specific form, it's to say your brain wants to get good sleep when it thinks you are safe and doesn't have other priorities. So if you're feeling anxious, you're not going to get good sleep. If you're feeling like it's loud out or bright out, you're not going to get good sleep. Even if you exercise right before bed, this is one I've experienced because I have this like indoor pickleball league, and sometimes I play till 10:30 at night, and I get in bed and I cannot fall asleep. It's because my body's saying, no, we're actually out. We're moving, like we're still experiencing the chemicals of exercise. So that can be another one to consider. But the back end of this is going to be that even if you do everything perfectly from a sleep hygiene perspective, you still may need additional help. So rates of obstructive sleep apnea are very high, and it's a condition that goes widely underdiagnosed. And so this is where talking to your primary care doctor or whoever your health doctor is or health practitioner is and saying, hey, do I need a sleep evaluation, is an amazing use of medical resource. Because what we know is not only do a huge amount of people have obstructive sleep apnea, restless leg syndrome, and other sleep conditions, but that these are treatable. It's not something where it's basically, look, you have this, there's nothing we can do. Obstructive sleep apnea, there's always improving technology around it. By the way, one of the things you can do is work with your doctor on weight loss, which turns out to be very helpful. A study was just published showing that GLP-1s can actually help with obstructive sleep apnea. So there are things that can be done there, but you have to know that that's the case. Side note here, having obstructive sleep apnea dramatically increases your chances of Alzheimer's, but when you treat it, it actually decreases levels of inflammation, and it can actually improve a lot of the cardiovascular metrics that tend to get thrown out of whack when you have obstructive sleep apnea. So if you're struggling with sleep, you've done all the basics, I definitely recommend talking to your doctor about getting a sleep evaluation. I think it's so helpful. And I can't tell you how many people didn't think they needed it, and then you get the results back and it's, oh, you have mild to moderate obstructive sleep apnea. What do you know? But now there's something to target and do something about. So some of the ideas around sleep. I do think, by the way, sometimes there's an indication for using sleep drugs, but sedative hypnotics scare me for a number of reasons. Maybe the most important being that they dramatically increase a person's risk for developing Alzheimer's disease. So while there are definitely indications to give somebody a sedative, sedative hypnotic, long term, these drugs are not ideal. And on that note, if anybody is considering the use of alcohol as a way to get to sleep, realize that you are dramatically interrupting your healthy sleep cycles. Same thing, by the way, with caffeine. If you consume it close to bed, even if you fall asleep, you still have some negative impact on your sleep cycle. So I say be careful with alcohol and be careful with caffeine.
Mm-hmm. Myself, I had to stop. I had to stop drinking caffeine. I used to drink in the evenings, but now, the last few years, it
Yeah,
definitely affects my sleep. Someone is asking about the
yeah,
magnesium. What about magnesium?
yeah. I think
Any
magnesium can be
studies? I mean, there's so many studies on magnesium too and sleep.
yeah. And I think just like what you said, so every body is different.
Mm-hmm.
And so don't just assume that because, there's some research on magnesium and other people benefit from it, that if you start taking it and you don't see the benefit, that something wrong with you.
Mm-hmm.
I think magnesium, for a number of reasons, is an interesting supplement. I mean, if you look at people's kind of rates of being magnesium insufficient, they're pretty high. So I think that can be helpful. And I'll do it sometimes before bed as well. I don't think it's anywhere near as helpful as the sleep hygiene when you apply it to a population. I think there's some placebo effect, absolutely, in having a routine. And again, it's just like the chamomile tea. Like there's a little data suggesting that chamomile can help people sleep, but it's not going to be the single thing for everyone. Similarly, there's some data suggesting magnesium can help sleep, but it's not like it's going to fix it for everyone. But if it's part of your routine, and you say, well, every night at 8:30 p.m., I have my magnesium, or I have my glass of tea, or I sit down and do my meditation, my mindfulness. It's more about having that thing you do that teaches your brain that this is the sleep wind down routine than it is about the chemical effects, I believe, of any real sleep supplement, with the potential exception of melatonin. I'd say that's one in which, there's a very clear kind of pathway that links melatonin with increased feelings of sleepiness.
Mm-hmm.
I see magnesium spray on the bottom of your feet.
That's very interesting. I never heard about that.
I am not either. I would probably put that one in the bucket of, if it works for you, phenomenal.
Mm-hmm.
And, it may not be that it's proven to work, but if it works for you and it's part of your routine, phenomenal, right? I mean, I think, one of the things that I'm trying to get away from is where I was when I was in training, which is to say, well, we don't have any great studies to back up that idea, so I don't recommend it. To say, look, whether it's something that has not had a ton of data around it, or it's something that maybe there's almost no data around. It's like, so what? If it's not hurting you and it feels like it works for you, then wonderful. As long as it's something that's, there are certain things. For example, people saying, oh well, I really want to take this 20-day detox set of products and supplements, and it's like, okay, well, what's in it? And then you look at what's in it, and it turns out that none of the ingredients have been studied, and maybe more importantly, we don't know what's in those capsules, and there's potential risk. But I think magnesium spray on the bottom of your feet seems quite innocuous, so I wouldn't be concerned about that. If that works for you, phenomenal.
So we see dementia and Alzheimer's disease, of course, more in women. Women are more at risk. And then the last few years, a wave of menopause hormone therapy. And of course, all the studies now started going on for women and estrogen, how it impacts. So any recommendation, any thoughts on
That's right.
that? Do you have any research going on, study on women and effects of hormones and decline in those hormones?
Yeah, I mean, what you're talking about is such an important thing. There's a couple of pieces to it. One is that historically and even now, women have been massively understudied, and people have not listened to in terms of especially brain-related stuff. It all gets kind of grouped into these buckets of basically saying, well, these are psychological issues rather than biological issues. And there's a number of medical terms that, we use to describe that. And it all is just kind of saying like, well, that's their opinion, but not the opinion of the doctors in biology. So it's a combination of the fact that women have not historically been studied enough, and their symptoms have been attributed to psychological stuff rather than biological stuff. And the best example of that is exactly what you described. So what happens after menopause? So higher rates of Alzheimer's, higher rates of depression, higher rates of psychological issues. And, at least in terms of the psychological stuff, it's kind of been attributed to, well, they're just going through menopause, as opposed to saying, well, what's actually happening in their bodies? Maybe the most interesting of the molecules in terms of hormonal changes is the estrogen. And I think Lisa Mosconi's work is the work I would kind of point out as being what I would send people to. She's written several books on this topic, the XX brain and others, to focus on how women's brains are different and how hormones influence them. But as estrogen drops off, estrogen is not just a hormone that is associated with fertility. Rather, in the brain, estrogen is a neuroprotective hormone, and it has immunoregulatory potential. And so there has been this series of discussions related to, well, if estrogen drop off, and because of what estrogen does, increases risk for mental health issues and cognitive health issues, should we replace hormones? Specifically, should we bring estrogen levels up to some level to be protective? I'm not putting out a general perspective on whether HRT is right for a person because I think that requires you to work with a practitioner. But what I would say is if you're interested to learn more, the person to learn from is really Lisa Mosconi. And again, she has a couple of books. We've interviewed her for both of our brain series.
Mm-hmm.
It's a nuanced conversation. I feel like people are always upset one end of the spectrum or the other when you start talking about HRT. Um, but I guess my personal position on it would be that I think that there is a bias towards saying that women's, especially psychological symptoms, are a function of them being women, as opposed to saying clearly something has changed biologically. And some of this has to do with these changes in hormones. So not only do we need to take those concerns more seriously, but we need to look at weighing the pros and cons of these therapies against psychological and psychiatric outcomes, not just other things. So whether it's cardiovascular or cancer or other things that do matter, we need to put that in the context of saying the most important thing is a person's brain state and mental state. And so I think a good practitioner is able to layer in all of those variables in order to make the decisions as to what works best for a woman.
Great. So one last question, and that's
Sure.
to your talks and all those modules or talks about with different people you did, experts, where public can have access to those, anywhere that you can guide
Yeah,
them.
so if you Google the science of
Mhm.
prevention, but we are planning to put out our series again, I think in about 2 months. So if people are just following me on social media or sign up for my newsletter on my website, which is austinperlmutter.com, I'll make sure to let everybody know when those go live again. But yes, we feature Lisa Mosconi prominently. There's a number of other experts that people may be familiar with specific to the brain space.
Mhm.
But we'll make sure, to let everybody know when that is being posted because it's a whole thing in order to, there's just all these different videos that we have to work on online to make sure that they can be watched because again, there's many, many thousands of people who will tend to watch those when they go live. There's lots also, I mean, people can access if they just go to YouTube or to my website and my blog. But for the comprehensive program, it's the science of prevention. And again, if you sign up for my newsletter or if you are following me on social media, I will let everybody know when that becomes available again. It seems like in about 2 months.
Listen, it was pleasure having you here today, and finally we got connected. That
Yeah, we
was
made it work.
great. It did work. It was great, and hopefully we meet again soon.
Fantastic. Well, thank you so much for having me and for this conversation.
Thank you, everyone, for being here with us today. Have a great day.
See you later.
Bye-bye. Bye.